not us. Sexual history. This is another one of those areas where it gets kind of embarrassing. And over time, it becomes more embarrassing for the patients than it does you, okay? I know whenever I was a rookie, it was extremely embarrassing for me to ask a female when their last menstrual period was. But after about the first 3 months and you do it over and over and over, it's just part of the job. And most, the way you ask it and when you ask it is the key. If you're at the mall and you have a female childbearing age having abdominal problems, is knowing when her last menstrual period is that important? Yeah, it's important. But asking right then, is it necessary? No. You can ask when you get in the ambulance or when you're away from everybody. I'm going to go ahead and tell you, do you know how many women I've gone out on who there's no way in the world that they're pregnant, but I don't know why why my stomach hurts? And guess what was wrong with them? They were pregnant. You ask them, when was your last menstrual cycle? Well, I don't remember, maybe a couple months ago, but it's normal for me to miss one every now and then. Well, are you sexually active? Oh. Are you, Well, guess what was wrong with them? Hey, they're pregnant. So, just go ahead and throw this out here as a precursor as you get towards medical emergencies. If it's a female childbearing age, abdominal problems, they're pregnant until proven otherwise, okay? Especially a possible ectopic pregnancy, because that will kill a female quickly. Inquire about urinary symptoms with male patients. Can be embarrassing for guys too. And one thing that I always want to put out there, because I get kind of frustrated, because we tend to be a female-centered society when it comes to like privacy and stuff, because we think, oh, guys don't care about their junk being out in the open or their sexual history and stuff, but I'm here to tell you they do. So ladies and guys, you need to be just as sensitive towards the males as you would the females, okay? And vice versa. There's a question on an assignment that I used to give to a class about sensitive history. And it used to always come up that females would be more sensitive towards issues dealing with reproductive system than guys. And I'm like, why do people say that? And it'd always be the women, because women always assume that we don't care. But we do. And guys will always come in with females about more of stuff like their menstrual cycle, or not so much more of a sexual history. And I'd always be like, why are we coming up with this stuff? Because, all of it is sensitive. And we need to be sensitive to everyone's needs when it comes to that. Because I get embarrassed about it. Or I would. I don't know if I do anymore, but, All right, so ask all patients about the potential for sexually transmitted diseases. Why do we need to know that?
What we're working on, what do we need to put on to protect ourselves? PPE, BSI?
Well, you should do that on everybody, right? Doesn't matter. We're not going to put on any more PPE. I mean, if there's a potential there, how do they know? But still, it has a lot to do with past medical history, and is that causing the signs and symptoms that they're having, and is there potential that they're pregnant? All right, so silence. You have the patient that is silent and doesn't want to talk, just like this class tonight. Doesn't want to participate, okay? Sometimes patience is extremely important. Give them time. They don't want to talk, give them time. Don't talk for them. Don't try to force them. You can ask them yes/no questions, and maybe they will nod their head or whatever. But don't give up on them, okay? And don't get rude or mean to them because they won't. Sometimes you'll have the overly talkative patient like me that y'all been trying to get to shut up all night, but I won't. So find out reasons why the patient may be overly talkative. Sometimes they're just lonely. People get lonely. You'll go out on grandma who is 89, 90 years old, and guess what? Nobody has visited them in weeks. And they just crave your attention. Sometimes that happens. Sometimes it's excessive caffeine consumption, and that's my second Coke today, so it's not that, okay? Nervousness, ingestion of cocaine. No, I haven't done any cocaine today. Have I, John?
Crack.
No, crack. Maybe crack. No. Methamphetamine. And sometimes if you have the overly talkative patient, you may need to summarize and ask them, hey, do I have this right? Are you telling me that your big toe is hurting because you kicked the door? Multiple symptoms. Sometimes this can just get off the map, but sometimes people have multiple things wrong. And sometimes I used to get frustrated. Now it's not so bad because we do electronic documentation. But in the day when it was all paper, and for the first 17 years of my career it was all paper, they only gave us like this little bitty line to put the signs and symptoms. And sometimes I flip it over and say, see attached document. Yeah. Yeah, because it'd be a lot. So expect multiple symptoms in our geriatric group. Prioritize our patient's complaint as you would in triage. So if your patient is complaining and they have a lot of symptoms, okay, and all of a sudden you're going through and the patient tells you, yeah, I'm having chest pain. Well, is the chest pain going to take priority over the leg pain? Yes. Start with the most serious and end with the least serious, okay? Anxiety. Sometimes, hey, people showing up in the middle of the night in ambulances, you're in pain, your patient's in pain. That can cause great anxiety for a patient. So expect them, patients that have anxiety, expect them to show some signs of psychological distress. That's where it's time for you to be comforting and to be confident about what you're doing. Reassure the patient and watch for clues of violence, because sometimes they become violent not because they want to be mean, but because they're scared. Anger or hostility. In my career, this is true. I've had more anger and hostility directed towards me by friends and family than I have the patient. Majority of your complaints, when people complain about you, won't come from the patient. Guess who it comes from? Bystanders and family members.
Because they don't like the way their loved one's being treated.
Yeah. So you need to make sure that you approach the entire scene in a professional manner. Remain calm, reassuring, and gentle to everyone there. However, if they're just unworkable, have PD deal with them. Remove them. Get rid of them. Have them leave. Intoxication. These are always difficult situations. So, do not put an intoxicated person in a position where they feel threatened. Remember, their inhibitions typically are lowered. So, they could be on the pose to attack. Remember, intoxicated people think they're 10 feet tall and bulletproof, right? So, don't threaten them. It does no good to argue with an intoxicated person. Nobody's going to win. Just let them yak. If needed, have PD there, okay? Be diplomatic, be non-judgmental. Sometimes you'll have the crying patient that just won't stop crying. And you'll get these, especially because if you respond to someone and there's a death, then they're really upset. Do they have a right to be upset? They could. That's them. So let them be upset. I got a phone call. We ended up running a call one night. And on the inside it frustrated me. However, we responded to Applebee's, and it was a fairly weird thing, because we responded to Applebee's and couldn't find a patient. The patient was in the parking lot in their car, and they were in there crying because their boyfriend took them to Applebee's and broke up with them. And she was too distraught.
So she called 911.
So she called 911. Huh?
I was asking the same thing.
So, however, that's not time. Even though you're kind of like, you called 911 for this, you still need to be kind, compassionate, caring. Remain calm, because I'm going to tell you, in that situation, if you would have smarted off or something, would that have made the situation any better? No. Now you would have been the object, and you could have gotten in trouble too. Now depression, we will run quite a bit of this. Out of this room, many of you will probably, if you have not already, suffer from depression once you've been working in this field. After you've run a couple kids who've been shot in the head, run over by their grandmothers, drowned in the backyard or whatever, you will probably suffer a little bit of this. However, we will deal with it appropriately, and we will learn more about dealing with that appropriately a little later. But it is not something to put a tag on someone and put a stigma on them, because it is a process, okay? It is a situation that does not demean or make anybody any less than what they are. It is the leading cause of disability worldwide. Symptoms include hopelessness, irritability, sleeping and eating disorders. And the only thing we can do in this situation is be a good listener. Remember, we are not Dr. Phil. Just listen. Don't give your advice. You're not licensed to give advice or anything like that. You're licensed to listen and document. If they ask you what you should or what we can do, the thing you can tell them is that, hey, we're going to do whatever it is to help you, and we're getting you to the proper people that can help you. There's nothing we can do about it. But if you give the wrong advice, guess what? Now you're liable for what you told them. Confusion behavior. This can result from hypoxia, stroke, diabetes, trauma medications, and other drugs. Geriatric patients could also have dementia, delirium, or Alzheimer's disease. Sometimes you may have to ask family, friends, or bystanders to get more information about what's going on with the patient. If the confusing behavior is abnormal, then you need to have a heightened sense of trying to figure out what's going on. If it is normal, like if they have Alzheimer's, then you need to document that as well, because you may be looking at a different complaint, not just behavior, okay? You know how many times we've gone to the senior center to pick up a patient, and we're getting one picture, but then the family's telling us another picture, and we need to get both pictures. Limited cognitive abilities. These patients are developmentally handicapped, and in these patients, you want to depend on the family or friends or caregivers to help you. Sometimes these patients won't let you get close to them, no matter what you do. You may have to enlist the help of the family to help you through this. Keep your questions simple and limit use of medical terms to them. And even though they may not understand what's going on, you still want to engage them. Don't just treat them like they don't exist. Talk to them. Even though they may be trying to push you away or whatever, stay calm, be reassuring towards them.